Hello, my name is Dr. Neeraj Agarwal. I'm a professor of medicine and director of Genitourinary Oncology program at the Huntsman Cancer Institute, University of Utah. And I'm joined here by Dr. Manoj Bupathi. Manoj.
Hi, my name is Manoj Bupathi. I'm a medical oncologist with Rocky Mountain Cancer Center and Sarah Cancer Research Institute. Thank you for joining us on this panel discussion. Dr. Agarwal, thank you for taking the time to join us this morning as well. Really appreciate your time and explanation of all these late and new upcoming therapies in prostate cancer, as well as kidney bladder as well.
My pleasure. Thanks for having me here. So I guess, Manoj, we can start with the questions first. We got a lot of questions here. Is that okay?
Yeah, perfect.
So I will start with the first question. How many patients are positive for PSMA antigen? So if you look at the results from the VISION trial, out of 100 patients, 87 were positive for PSMA antigen. And positivity is defined as any lesion which has a higher uptake than the liver lesion, liver uptake. So liver uptake is considered standard, and anything above liver uptake is called as positive uptake. So 87%, I would say 90%. So vast majority of patients were positive. Any questions on that? If you have any questions, please leave your comments here in the comment box. We'll be happy to answer that. I do like to comment on one more thing regarding the positivity. If patients had a lesion which was big enough, so say 2 or 3 centimeter lesion, metastatic lesion, but that was negative for PSMA uptake on the gallium PSMA scan, that was an exclusion for this trial. And the reason it was they were excluded because this suggests a neuroendocrine differentiation in this heavily pretreated patients. So just to keep in mind, there's not only positivity which is required, but also we cannot have a patient who is negative for a big lesion, because it is likely that they're not going to respond or going to quickly progress on the lutetium therapy. So thank you very much. Anything else, Manoj?
I have a quick question. When are you using PSMA scans versus Axeman scans versus standard imaging? How do you pick?
I think it is a easy decision right now because we don't have gallium PSMA scan available. But within next 2 or 3 months, we are going to have these scans being available all over. And in that case, I would prefer, in my view, I would prefer a PSMA PET scan because there are therapeutic implications of that. So if a patient is PSMA positive, I know, especially in the heavily pretreated metastatic castration-resistant prostate cancer setting, I know that I have lutetium, hopefully will be approved by that. So I think that's a therapeutic implication of that. Regarding diagnostic implication, I don't think we have a robust prospective study comparing lutetium or PSMA PET scan versus oxium PET scan. I think it will be nice to have a study in the context of biochemically recurrent setting. If there was a study done, probably I'm not aware of the data, but I think we need that kind of trial to confirm one scan is superior over other. But until then, I would continue to prefer PSMA PET scan once it is available.
Somebody had asked in here, has made a comment saying that we cannot get the gallium scan in Colorado. Is it available to you in Utah? Just a quick note on that. So it is actually available in Colorado on clinical study. So we do have a bispecific molecule for PSMA that is currently on study at multiple centers in Colorado. So for patients that are going on to this study, they can get the PET PSMA. It should be available. I don't know if it is available to you in Utah, Neeraj.
As you said just now, we do not have it available right away, immediately, but we should have the PSMA PET scan available within a month at the Huntsman Cancer Institute, hopefully 6 weeks, as a part of a study. So patients can get the PSMA PET scan done for actually free without any cost, as long as they're eligible for those particular eligibility criteria, such as PSA recurrence after definitive therapy, and so on. It should be commercially available in 3 months. That's my hope. That's we are looking forward to. And not only Huntsman or Utah, I think it will be available all over the US within next 3 to 4 months.
I would agree.
And I think that will sync with the approval of the lutetium PSMA drug. So I don't think we're losing out on anything until that.
I'm just going to jump to a question from the kidney bladder session. It seems like there were several people that had asked about how do you select between pembrolizumab plus axitinib versus cabozantinib plus nivolumab, ipilimumab plus nivolumab, or even pembrolizumab plus lenvatinib. I think this is a tough question. I don't think this is an easy one to answer, to say that this is the patient population that I would pick this one with, or that combination with. I mean, as you guys saw, the data for Ipi-Nivo, when you look at complete response rates, it's still higher compared to all the other combinations. You look at bone metastases, cabozantinib may have a slightly better advantage. You look at overall response rates, maybe pembrolizumab plus lenvatinib, maybe a slightly better. Toxicity profiles are different among all these combinations. So I think how I generally make my decisions is based on really toxicity with combinations. That's one aspect. The other aspect is also pathway driven, at least in community oncology, which one's on pathway, which one is not on pathway. And the other aspect is also comorbidities and frailty, and how frailty. Neeraj, do you have thoughts on how would you pick?
So if a patient comes to me with intact kidney, so de novo metastatic renal cell carcinoma, and there is a clinical trial going on known as probe trial, where you think patient may have nephrectomy done, and many urologists still continue to prefer a nephrectomy in certain type of patients who have locally large renal lesion. Say, I'm just going to give you example, a 18 centimeter primary right renal mass with 2 or 3 lung metastases, which are 1 to 2 centimeter in size. I think in this case, if patient has good performance status and has belongs to low intermediate risk category, you can justify nephrectomy in this patient. So if say you have a patient who may be a candidate for nephrectomy, I think I would start the patient on Ipi-Nivo, because you can do surgery while patient is on Ipi-Nivo. They cannot be in a wedge of TKI if they are contemplating a surgery. As you just said, Manoj, if patients have bone metastasis, cabozantinib was unusually more efficacious over everolimus in the Meteor trial in patients with bone metastasis. Hazard ratio, if I'm recalling correctly, was in the range of 0.3, so 70% reduction in risk of disease progression. So in those cases, if I see bone metastasis, high volume disease, and I know Ipi-Nivo may not get time to catch up, I think I tend to go with cabozantinib nivolumab combination. And I'd just like to mention one thing really quick. In our own study, which we did with International Metastatic Renal Cell Carcinoma Consortium, known as IMDC, and we all know about IMDC risk criteria, also known as Hanks criteria, we showed that 50% patients will not get next line of therapy. In all our practices, we lose almost 50% patients with each line of therapy. So if somebody had a high volume disease, rapidly progressive disease, I would use a VEGF TKI plus an IO. And if I'm picking one of those VEGF TKI IO combination over Ipi-Nivo, I'm going to pick up the strongest, most efficacious combination. And to me, those two combinations are Cabo-Nivo right now and Len-Pem or lenvatinib pembrolizumab. Both have very strong hazard ratios for PFS. Now, among these two, I think we all can look at bone metastasis, insurance status, and so on. I think both are very good combinations. And we'll have to just think about how we are going to sequence these drugs down the line. So lenvatinib, if you want to use Len-Ev, like lenvatinib everolimus, want to keep it for later use, I would go with cabozantinib and nivolumab in those patients, and vice versa. So long answer, but I think it was a very, as you said, tough question because we do not have comparison data between these regimens.
Yeah, I would agree. One of the other questions that came up was, at what dose do you start, and do you use 20 milligrams of lenvatinib? Personally, I have never been successful in using that high of a dose. For me, it's always been around 14 milligrams that I've been able to use. So I tend not to start at 20 milligrams just because sometimes these patients can be quite symptomatic from their disease. And if you start them at a higher dose, then they tend to fail. So I always titrate up rather than titrate down. But that's just been how so I usually start around 14 milligrams and then go up if I can. How do you do it, Neeraj?
So in patients who have very good performance status, high volume disease, the very reason I'm contemplating a VEGF TKI plus IO regimen, in those patients, I tend to go with the higher dose, Manoj, and then quickly taper off, do the dose reduction if they are not able to tolerate. That's my strategy. Now, if I'm using len-pem in a relatively frail patient in second line, third line, please note that NCCN guidelines endorse these agents to be used in salvage therapy setting also, mainly because if somebody have not used or not had a chance to use these regimens up front, they ought to be able to use it. They should not have problem from reimbursement perspective. So if I see a patient who is already progressing on first line therapy and is frail, I think I will go with the lower dose. Please also note that we have a trial going on in this setting, known as Contact 3 trial, led by Dr. Monty Paul, Dr. Tony Sherry, where patients are being randomized to cabozantinib versus cabozantinib plus nivolumab or atezolizumab, sorry.
Yeah.
So if you have a patient progressing on ipi-nivo or lenvatinib pembrolizumab, they can get this combination, these drugs for free, basically, cabozantinib versus cabozantinib with atezolizumab. So just giving a shout out to that trial.
Yeah. Should we go to a prostate cancer question? I see one in the chat here. I don't know if you have other prostate cancer questions.
I think I can go through those questions first, which have already been asked. It's very nice to see the passionate audience and enthusiasm for these ASCO data. So one question is, there seems to be no PSA or Gleason score in the study protocol. Is there any correlation with these values and the potential presence of PSMA? I don't think we can, there is evidence to support that high Gleason score will have low PSMA and vice versa. I think this is a great thought. I will not base my decision to use lutetium based on PSA or Gleason score. I personally would stick to the criteria, eligibility criteria, or the approval criteria. We will see how FDA is going to approve this agent. It is possible that FDA may not require a diagnostic gallium scan or PSMA scan because 90% patients were positive. If that happens, then I would basically, anyone progressing on taxane therapy and a novel hormonal therapy, I would offer lutetium. If FDA mandates that we do these scans, I will do these scans, but I will not base my decision on PSA or Gleason score. The next question is, confused on exclusion criteria. Can they take chemotherapy and or hormonal therapy like Xtandi concurrently? So please note that in the lutetium trial, patients were randomized to lutetium plus best supportive care versus best supportive care, or the standard of care, I would say. The standard of care excluded the following: chemotherapy, radium, or any drug other than novel hormonal therapy, pretty much. So these patients who were progressing on novel hormonal therapy, such as abiraterone or enzalutamide, and they were progressing on a taxane, and they were allowed to have more than one taxane. In fact, many patients received 2 taxane therapy prior to going on the trial. So if you look at those patients, these patients were randomized to the standard of care plus lutetium versus standard of care, and standard of care agents given to these patients on the trial were novel hormonal therapy, so alternate therapy such as abiraterone, enzalutamide, apalutamide, and so on, and bone strengthening agents such as zoledronic acid and denosumab. So these were the therapies which were obtained, which were received by these patients on the control arm of the trial. So based on that, I will not use chemotherapy concurrently. I will not use radium concurrently. Radium is alpha particle, lutetium is a beta particle. I do not know how they are going to interact on the bone marrow especially. So I will not use those agents together. And chemotherapy is obviously will not be allowed with lutetium. Sickle cell T is not in consideration here. It's a pretty advanced form of disease, so I won't even bring that up. So yes, enzalutamide, abiraterone, apalutamide, you can use any of those agents with lutetium. And the last question here is, we will need availability of PSMA PET scan before using the drug. Am I correct in this assumption? Answer is, we do not know yet whether FDA is going to approve lutetium based on a positive PSMA PET scan. 90% patients were positive. So I am not sure if we will be required to have PSMA PET scan, but let's see what the label will be. It is a matter of, I think, weeks rather than months before we know the answer. Manoj, there's last question here. May I just cover that up?
Yeah, absolutely. It's talking about the sequencing. Yeah, absolutely.
This is alarming that ADT intensification is lower in African American men, given category 1 versus 2 recommendation, and under treatment given what we know now. Thoughts to way to improve this. So I'd like to bring to your attention is the data we presented in ASCO. We did not see, so first of all, we saw lack of use of ADT intensification therapy. So ADT plus docetaxel, enzalutamide, abiraterone, apalutamide, across the board. 70% patients, did not matter whether they were white or they were African American, they were Hispanic, they were Asians, everyone received across the board. There was a low use of ADT intensification. Within that low use message, the African American men had lower use, but I think it was not statistically significant, but numerically there was a lower use among African American men. I'd like to point out that even though African American men have more aggressive disease, they have higher Gleason score, across the trials we have seen so far, they have better response to systemic therapy with novel hormonal therapy. And that could be related to the androgen signaling driven tumor predominantly in African American men. So it is even more unfortunate, in my view, to see this happening across the board. It's very disappointing. So I think there are a lot of things we can do together, and basically there's no excuse for us. This is a medical legal issue possibly if we did not treat patients with ADT intensification upfront. So everything we can do in our capacity, I think we should do to improve the use of ADT intensification. One thing I would like to quickly add in 20 seconds. When I see a patient for the first time with newly diagnosed metastatic prostate cancer, I bring up ADT intensification at the same time during our first visit, because by the time you have the patient come back for the second visit after 2 or 3 months, PS is already improving. Patients are feeling better. They will not listen. They will not really pay much attention to ADT intensification at that time because they're already doing well, only to realize that they will progress after 16 months rather than 40 months if they are on ADT intensification. So I think the best way to improve the use is to spend time with the patients on the first visit and talk about the data. Manoj, we have 1 more minute.
Yeah, so I have one question that I wanted to address, which was looking at PD-L1 status in the neoadjuvant gemcitabine plus cisplatin plus nivolumab trial. And in this study, actually, PD-L1 positivity was not directly looked at as far as I'm aware. And I believe the reason was, previously, when you have DNA damaging genes, we know that those patients respond pretty well to cisplatin and there's already been data that showed that when you have alterations in DDR, you actually can have increased response or increase in tumor mutational burden. So as far as I'm aware, there's no specific PD-L1 status that was looked at in this study. So I think we're out of time.
I'd just like to add PD-L1 expression is a highly unreliable marker.
Yeah.
And I would be very hesitant to use PD-L1 expression to decide on treatment options. If patients are so frail that they cannot even get carboplatin chemotherapy, I doubt they are going to respond to single agent PD-L1. So there are multiple reasons I do not rely on PD-L1 expression.
Agree. So since we are out of time, thank you all for joining us. We have a quick break. There's still time to earn points towards the Engage and Win giveaway by chatting with our industry representatives in their exhibitor hall. Within their booths, you'll find helpful resources, information, as well as the ability to talk with them, talk now with an available representative. Thank you, Dr. Agarwal, for a great conversation. Always a pleasure to work with you, and thank you for this opportunity.
Thank you for having me. It was a pleasure.